this session is going to be a bit different because we're taping it, so it's going to be a bit more teaching orientated for the video. All right. Now, what was the two principles I stressed a lot in terms of what are the underlying teaching principles for the respiratory examination that we're trying to do and evaluate patients' condition? Can you remember that? We are trying to do this and doing this. That's sort of the... Soupy, you will be the patient. There's your seat. Make sure you put on a sticky label. Yes?
One is generating sound.
Generation of sound. So we use the sound. How do we generate the sound? Two mechanisms.
Through the mouth.
Yeah, so turbulent airflow breathing as opposed to... Okay, so we want turbulent airflow in the upper airways, or lower airways as well, to generate sound through that. Yes, and what's the other way? Speech. So we use our vocal cords to say 111, 99, I'll be back. Variety of slogans that we use to generate sound, and we evaluate how that sound travels through the lungs as we interpret it on the chest wall. Yes? Right. What is the other principle? Somebody from this quarter here. Soupy, you can redeem yourself if you can tell me that.
Other principle.
Were you in my briefing? Okay. Any idea what is the other sort of principle we're trying to use in the examination? What do you feel? Yeah, we do use our hands, yes. So that's how we evaluate what we've generated. So we generate sound. What's the other thing we ask the patients to do so that we can evaluate the lungs?
Breathe.
Okay, yes. Keep breathing.
Maneuvers.
Maneuvers. Close. We want to have movement of the chest wall that we need to evaluate. What is the principle of a diseased hemithorax or lung? Will it move or not move? Yeah, so there's decreased movement in that part of the chest that is where the pathology is located. So a pneumonia or a pleural effusion or a big lung CA, it will have decreased movement on that side. So that's very helpful. If you immediately pick up there's lack of movement on this side, this is probably the side that's pathological or the pathology is located. It's really helpful. Okay, so those are the two basic underlying principles, and you'll see how they come through as we go through the exam, how they feature quite a lot. All right, any questions? Remember, questions are very helpful and very welcome. Right. Now, I'm going to quickly talk about that black section at the moment, because I've summarized the important aspects under inspection, palpation, percussion, auscultation in your respiratory examination. The reason I've done that is because after the previous OSCE, I realized that students are obsessed with body hair. So they keep commenting on hair growth and normal hair growth and no abnormal hair growth and there is hair here, there's no hair here. So I've realized to avoid that, I need to tell you what is the important inspection aspects. So hair, not that important in respiratory. Alright? So after the general inspection, which we'll go through in a moment when we get to the exam, the general focus, stuff that is important to comment on and report in the respiratory examination when we look at the patient's thorax is deformities of the thorax. The most important one is the most common one as well,
Barrel chest.
barrel chest. So that is the patient who has this huge hyperinflated lungs from COPD, and they have a barrel chest. And how do we define a barrel chest? Tapelu, can you help me? Yeah, so normally the lateral aspect, if you look at a patient from the back, the lateral dimension is sort of much more than the AP dimension of the chest. But if the AP one gets bigger, closer to the lateral one, you get a barrel-shaped chest, which is a sign of hyperinflated lungs because of air trapping and obstructive airway disease. So chronic severe asthma can give you that eventually, but the most common one in a smoking population is chronic obstructive pulmonary disease, COPD. All right. So chest deformities. The other deformities that you would have seen in Talley and O'Connor they speak about, pigeon chest and the funnel chest. Now those are interesting and quite dramatic to look at, but probably not so clinically significant. Which other deformities, which you get more in the geriatric population, mostly, has quite an effect, or could have quite an effect on the functioning of the lungs?
Kyphosis, maybe?
Yes. So the kyphoscoliotic patient who sits in the chair like this, and who sort of causes a restrictive compression on the lungs, and it restricts proper breathing, essentially. So that's deformity. So that's a good one to report your finding on. The next one is scars. So pneumonectomy or lobectomy scars, previous operations or major trauma to the chest wall, those things. So actually, those are the two things to focus on. I don't want you to focus on chest hair. Okay. Please. All right. Then we move on to palpation. Now, the three things I've got there is tenderness, expansion, and fremitus. So when we do the palpation of the thorax in the front and the back, we need to check that the patient doesn't have a tender thorax wall, chest wall, secondary to trauma, secondary to inflammation after a viral infection, a costochondritis. Now, of course, your history would be very helpful to try and, if the patient complains of chest pain and he said he fell on the wall or bumped his lungs, his chest against something, yes, then you would suspect a chest trauma and the painful tender chest. So it is important because sometimes patients complain of chest pain after a viral illness and people worry that it's cardiac, which could be, but you need to just rule out that he hasn't got a costochondritis, which could be an important sign of symptoms. So that's what tenderness. Well, that's a very quick and easy way to examine that. Then expansion, and that is the one you need to focus on in your technique during this day of practice. That's the most difficult thing for students to get right subsequent to percussion. Okay? So we'll talk about percussion technique in a moment. But if you have one thing and you take away from the session, you can practice all the other bits, not very difficult, but how to do chest expansion, your technique, and how to practice. You need to do that today. Ask any of us who's helping here to check your technique. Have you got a good technique? Are you happy? Do you have questions? Promise me you'll do that. That's the one thing that's going to cause me a lot of giggles in the OSCE if it comes up. How do people do chest expansion? Okay. Now, fremitus. What is fremitus or vocal fremitus? Yes, Rupi, you may answer. Where's your badge?
I still have to get it. But fremitus is like when you touch the patient's chest and then he says like 99.
Yeah.
You hear.
Yes.
I don't know.
Will you hear or will you feel?
You feel something in the chest.
What do you feel in the chest?
Vibrations.
Vibrations generated by
So,
sound. Yeah, absolutely. So that's where the sound principle comes in a lot. And why do we do that test?
to see if the sound is being distributed, like if there's airflow in the lung, basically.
Okay, not to check if there's airflow.
Increase consolidation.
That's one thing, but that's more specific. What's the principle?
To see where the air is in the lung. So distribution of air.
Yeah.
I want to see if there's a difference between the two sides.
Okay, that's the application. So what do we try to do with the sound that we generate? We are trying to evaluate how the sound conducted through the lung tissue. So we have sort of a normal levels of conduction, and then we can have some things that increase the conduction ability and decrease the conduction ability as you perceive it on the outside. Okay? So with increased fremitus, that is because you have better conduction through the lung tissue, and what will give that? Umuno?
Oh, consolidation.
And what is a consolidation? Absolutely correct.
Let's say fluid in the lung.
That's a bit vague. Give me an example of what is a consolidation.
Like in pneumonia,
Yes, what type of pneumonia?
lobar
Lobar pneumonia. And what is the pathogenesis, Shirish? Yeah, well, that's an infective one. Gets it. But what happens in a lobar pneumonia that gives you consolidation and increased conduction of sound to the chest wall? The pathogenesis. I'm talking getting to the physics now. Wait for Shirish to say, or you can phone a friend if you don't know. This is an opportunity to shine.
Like fibrosis in the lung.
No, there's no fibrosis, hopefully.
Necrotic.
No, not yet, hopefully. There's not an abscess yet. There's pus, in the alveoli and in the terminal bronchiole. Yes? That displaces air and it becomes a solid bit. Now, the sound that you generate through your vocal cords is within the airway system. So what did we say? If you generate sound within a more solid environment, it helps the conduction more solid as opposed to air. So, but now that's why the vocal fremitus and the resonance will also be increased because of the better conduction. So what will decrease your conduction?
So, does I also got a
Yeah.
question on it?
Yeah.
But isn't, how accurate is it? Because isn't it like, doesn't it depend on the thickness of the chest wall?
Of course. Multiple factors. I will talk about. So it's not 100% perfect. Depends on the patient. Absolutely. Talk about it in a second. What will decrease your fremitus and resonance? Pleural effusion, pneumothorax, hemothorax. What's the collective theme that comes out? Apart from thorax. What's the collective theme? No. So it's anything that increases the pleural space. Fluid, air, blood, pus, anything. Because it will be a damping effect to the sound coming through to you on the outside. Alright. Now, here's an important one. Yes?
If pus is on the pleural space, it will cause...
It will be a sick patient, yes?
No, other times says pus can cause either consolidate or like reduce the sounds or increase sounds depending on where it is on the lungs.
Now tell me why. Why does it, when it's in the alveolar space and it's a consolidated lung, you have increased conduction? But when it's in the pleural space, you have decreased.
Change in sound conduction through the different mediums.
Yeah. So the pleural space is not in the airway lung system, it's outside of it. So if you have fluid or air or any other media different than the lung tissue, the sound has to cross a barrier. And that's why it's dampened. It's like you under the water and I'm outside of the water trying to speak to you. But if we're both under the water, you can hear sound solid, better. Although you won't understand what I'm saying. Okay, does that make sense? That's a very important principle, the physics. Right. Now, fremitus, vocal fremitus, you examine with your fingers the vibrations. Yes, depending on the soft tissue levels of the patient, it will affect what's coming through to you through the skin. If it's a big patient with lots of soft tissue, the vibrations will be filtered. If it's a very small young baby who's crying, if you touch their chest, it's like an orchestra vibration because of the incredible vibrations, because there's so little soft tissue. So the less soft tissue, the better you can feel the vibrations. You can also ask the patient to say the words louder, 1, 1, 1. That will increase the vibration. Also, depending on where you feel on the thorax wall, there's different levels of soft tissue. Over the pectoral muscles or in between the scapula where the rhomboids and the trapezius is, there's more soft tissue. So it's less palpable, the vibrations, than over the lung basis or in the axillas. So these things all factor into how you experience vibrations and the fremitus. The important thing is comparing left to right. And in conjunction with other tests like expansion and listening, you can come to an idea what's going on inside the lung. Now, second point. Fremitus and resonance test the same thing. The one is sound with vibration and feeling on the chest wall. The other one is sound with a stethoscope and evaluating the sound, as opposed to the tactile vocal fremitus which you feel. So it's the same thing that we test. So you can decide which one you want to do in your examination. I prefer resonance. Why? Because I feel I can better evaluate left versus right with my ears than with my fingers. Secondly, the patient needs to speak softly, which is helpful in the clinic if the patient doesn't need to shout 111 all the time. So they can just say 111, nice and it is not hard, not loud. And I feel it fits better in my examination. But you can go for fremitus, then you can leave resonance. Or you go resonance and leave fremitus. We teach you both. I want you to practice both and then decide. When you get to an examination, pick one. and do one of them. All right? But just do it properly. All right. So that's fremitus and expansion. So that's palpation. Happy with palpation? We do that front and back. We do everything in the front and the back, and I'll show you how to do that. Then percussion. Can I just show you the technique again? Okay. Say this is the zone I want to percuss. You put your middle finger over the area. So if it's on the chest wall, you would go in a horizontal fashion to try and get in between the ribs. Because you want to get your finger as close as possible to the organ you're trying to percuss. So you need to give a bit of pressure to sort of fixate your finger and compress the soft tissue closest to the organ you want to percuss. Then you need to lift your other fingers up a bit with compression, your focus of compression of this finger is over the middle phalanx, not the tip or the base, but sort of middle phalanx level. You want to get that bit close. Lift the other fingers so that when you percuss, you don't dampen it with your fingers on the side. Lift the other fingers, then it's a floppy wrist and a firm distal phalanx as your hammer, if I can call it that. Now, yes, you need coordination, not... Okay, so there we go. Okay, so if you want to have a good thing with your confidence, these examination beds are wonderful for confidence. Now, that's the principle. The principle is compression and a hammer that produces sound. You can use two fingers. You can use the index finger. That's not important. The important thing is the principle underlying it. Okay, so I think that's what you need to practice. So during percussion, we percuss all the zones in the lung. So the front for the upper lobes, the axilla. So on the right hand side, it's for the middle lobe, and on the left hand side, it's sort of the lingular area of the left lung, and on the back, it's mostly the lower lobe, specifically over the lung bases and just between the scapulas. So remember, when you examination, cross the arms of the patients to move the scapulas away, so that you're closer to the lungs, which you're interested in. All right. Then, getting to auscultation. So I've got BS, AS, and resonance there. So what does BS stand for?
Breath sounds.
Yeah, breath sounds, not bowel sounds. Okay? So what are the three breath sounds that we use, or that we have, according to Kevin? Yes, Candace?
Vesicular breathing.
Vesicular,
And bronchial breathing.
bronchial,
And
amphoric. Excellent. So those are the three ones. And which of those three would we consider as the normal one? Vesicular. Okay. So vesicular breathing is when the air flows nicely into the aerated terminal bronchioles and alveoli. So I would say that's the gas exchange level. Right. Now, when you have a patient breathing with an open mouth, causing nice turbulent airflow in the airways, you can sometimes have it quite loud, and then that's when people talk about this bronchovesicular breathing, which is normal, but it's louder than just pure vesicular breathing. Okay. So when you guys are examining one another, and you can take nice deep breaths through the mouth, you'll hear I can hear the airflow quite nicely, and there's a bit of a bronchial component to the vesicular breathing. That's why it's called bronchovesicular breathing. That's also normal, right? But if you are not sure what you're experiencing here, do ask any one of us to give you some advice. Now, on that point, what's happening a lot with the examination is somebody finds one sign, for instance, the fremitus is a bit more than this side than this side, and then they think the patient has a pneumonia. But the patient has no increase in respiratory rate, there's no fever. You need to look at it in context of the patient. So when I get to you, you say to me, I think, Devin or Nikita has got pneumonia because there's increased fremitus. Then I say, what's the respiratory rate? Then you tell me, it's 12. Then I say, no. Okay, so it needs to fit together to make a nice picture. All right? So that's the breath sound. So bronchial breathing. What's the pathogenesis of bronchial breathing? Having just heard our discussion on the other aspects of pathogenesis. Marcel, any ideas?
Well, it's when there's turbulence in the lungs, and it's like a hollow and blowing type of thing.
I think you're on to the next one. Alden, any ideas? What causes bronchial breathing? Fanny. Okay, who knows?
Dilatation of the airways.
Mm-mm.
Consolidation.
Consolidation. Okay, continue, Nikita. You're on a good roll now.
That's what I thought. I don't know a lot.
So why would pus in the alveolar space in a lobar pneumonia give you bronchial breathing when you listen over here as opposed to vesicular breathing? Listen to the word bronchial breathing. So what are you hearing when you're listening here? The sound of the bronchus. So that's how airflow in the bronchus. But how on earth is that possible that you can hear the airflow in the bronchus from here?
It's better conducted because of the concentration.
Remember what we said in Fremitlis and resonance? The conduction is better through that solid part of the lung. So that's why you have better conduction for sound waves, but now you also have better conduction. So what you're actually hearing is you're hearing the turbulent airflow in a nearby bronchus through a consolidated lobar pneumonia. So that's one of the signs of consolidation is bronchial breathing. And how can you simulate bronchial breathing? How can you find out how it sounds?
It sounds like
But how can you get to the bronchus if you don't have a diseased lung? Where is the nicest bronchus to access? The trachea. It's the biggest one. Okay? So if you put your stethoscope over the trachea and take a deep breath in and out, you will. That is excellent. That is how bronchial breathing sounds. So inspiration, gap, expiration, and it's quite loud. It's with a gap in between. And inspiration and expiration is similar length. Okay, so you can simulate it. Please do not in an exam. So I'm just going to listen for bronchial breathing. And listen over the patient's trachea. No. That's where you can find out how it sounds. But when you listen peripherally in a patient who is sick, and you hear that over an area that's not moving and maybe has increased fremitus or resonance and there's bronchial breathing, you're going towards a lobar pneumonia.
So if you're doing that and you're not sure if it's bronchial breathing, can you check over the patient's trachea?
No, you can. But I mean, at the end of the day, you need to use all the signs in conjunction. This area will sound quite different from this area, which does not have a bronchial, hopefully, bilateral pneumonias. All right? So is everyone happy that a consolidation will give you increased fremitus, increased resonance, and bronchial breathing? All right? And the mechanisms, the pathogenesis is critical. It's better conduction, you're hearing the turbulent airflow in the nearby bronchus. All right. The last one is amphoric breathing, which somebody has mentioned. That's when you have a cavity in the lung, mostly secondary to which condition? Tuberculosis, cavitous lung disease. And there is a communicating bronchus, which has now got a cavity with a bronchus over it, and there's a hole in the bronchus which communicates with the cavity. So when the airflow flows through the bronchus, it's like when you blow over the beer bottle. You get that woo, that hollow, blowy sound. That's amphoric breathing, which makes you think of there's a cavity in the lung. Right. Is everyone happy with that? The pathogenesis? Yeah.
So I want to go back quickly.
Yeah.
You said the increased fremitus, increased bronchial breathing, and then increased resonance, isn't it?
Yeah, because fremitus and resonance is the same thing. So the one you listen and you hear, better conduction of sound quality, and the other one is more vibration in your hand.
So I was thinking of percussion.
Yeah, we'll get to percussion. So what does percussion give over a consolidation, as opposed to a aerated piece of lung?
Dull.
Yeah, dull. So how can you simulate dull percussion? If you want to get an idea how that sounds or how that feels. Yeah, you percuss over a solid organ. Okay, so the liver is quite accessible normally. All right, so that's what you can do. So that's, yeah.
Can you repeat the differences of the amphoric breathing?
So amphoric breathing, a patient has tuberculosis and in post-primary TB he develops a cavity in the lung, but the cavity communicates with the bronchus. So there's a hole in the bronchus which communicates with the cavity. So when you take a deep breath and the air flows through the bronchus, it creates a blowing sound over the cavity. It's like when you take the beer bottle and you are the bronchus and you blow over it, you get that whoo sound. And that's what you generate with amphoric breathing. It's also described as the ultimate bronchial breathing, because you hear that bronchial sound. Okay, Happy? Cool. So that's breath sounds. Additional sounds? What's the 3 additional sounds that we... Wheezing, stridor, crackles. Right. Now, which of those 3 do you not need a stethoscope for? Well, severe wheezing probably not, yes. Stridor. Now talk to me about stridor. What is stridor?
Obstruction in the airway, therefore when you breathe in the upper airway, therefore when you breathe in, it makes a sound.
It's an inspiratory, high-pitched squeaking sound secondary to an obstruction of the large airways. So the key words is inspiratory, high-pitched squeaking sound, large airway obstruction. Like in croup in a baby or a foreign body. Right, that will give you that sound. Okay, so it's that squeaking high-pitched sound. How does that differ in terms of sound and pathogenesis from wheezing?
It's expiratory noise.
So wheezing is mostly expiratory. It can be inspiratory if it's severe, but it's mostly expiratory, yes?
Small lower.
It's lower or small airway obstruction. Common causes asthma and COPD, yes. Okay. And you also, if you think about it, if your small airways are obstructed, it prolongs your expiration to get rid of the air, so you get air trapping. That's why you get hyperinflation eventually, because of the trapping of the air. And you get a musical sound, because it's go... So if you think about whistling, you need a small hole to get a whistly musical sound. Alright? So the pathogenesis is normally inflammation, which causes a bit of swelling and edema around the small airways to the size that they are becoming whistling as the air moves there. And they trap the air, takes longer to get rid of the air. So it's prolonged expiration with wheezing. Yeah, so that's when you have diffuse wheezing all over the chest. What will give you localized wheezing? So same pathogenesis, but in a local area. How will that work? No, that's diffuse disease. Obstruction. How can that happen?
You breathing in a foreign body.
Yeah, so a small foreign body. A small foreign body that goes quite distally and sits in an area that causes a bit of wheezing in that local area, yeah? What else? Can you give me something else that will give that? It will also cause small airway obstruction. Yes?
A tumor.
A tumor, yes. So a tumor that compresses a bit of the local small airways in the area can give you a bit of wheezing around the tumor. Okay. So if you have wheezing unilateral or one local area, you need to consider different etiologies. Okay.